Muy buenas tardes a todas y todos. Muchas gracias por estar acá, profesores, estudiantes y público en general. Es un gusto contar con la participación de la profesora Dana Olstad el día de hoy, en el marco de una visita que se gestionó como un esfuerzo conjunto entre la Escuela de Nutrición, el Centro de Investigaciones en Tecnologías de la Información y Computación y la Escuela de Salud Pública. La doctora Dana Olstad es profesora asociada en el Departamento de Ciencias de la Salud Comunitaria de la Universidad de Calgary, en Canadá. Ella es nutricionista, dietista registrada, máster en nutrición y metabolismo y doctora en nutrición. El trabajo de la doctora se relaciona con nutrición y salud pública principalmente y utiliza métodos cualitativos, cuantitativos y mixtos en su investigación. Como antecedente, sabemos que los grupos socioeconómicos vulnerables tienen patrones dietéticos de menor calidad que sus contrapartes, y estas diferencias tienen consecuencias negativas para la salud a lo largo de la vida. El trabajo de la doctora Olstad investiga las tendencias en estas desigualdades, las causas de las mismas y el impacto de potenciales intervenciones para reducirlas. La razón de ser de su trabajo es informar las políticas, tanto dentro como fuera del sector salud, para garantizar que todas las personas puedan acceder a alimentos nutritivos que beneficien su salud a largo plazo. La presentación que nos compartirá el día de hoy se titula Inequidades en Calidad Dietética y Salud, Tendencias, Mecanismos y Soluciones en Política. Comentarles que la charla será en el idioma inglés, sin embargo, tenemos 3 puntos durante la presentación donde haremos una pequeña pausa y un recap para hacer como un resumen en español de lo que ha ido conversando para que podamos, ¿verdad?, seguirle el hilo. Entonces, bueno, le agradezco a la profesora Olstad estar acá el día de hoy y le cedo la palabra.
Gracias. That's about the extent of my Spanish, so hopefully some of you speak English so that you'll understand most of my presentation. I'm really happy to be here. I'm from Canada, the University of Calgary, which is in Western Canada and where it's currently still snowing, even though it's supposed to be spring. So I'm pretty happy to be here in Costa Rica where it's nice and warm. So a lot of my research is motivated by this particular framework. So you may have heard of the World Health Organization, and they have developed a framework that talks about how the social determinants of health influence our health. So I don't have a pointer here, so I'm going to try and just orient you to this particular framework. So what it says here is that we have factors in the socioeconomic and the political context. So this is things like policies, national policies, provincial policies, and they influence how power and wealth and money are distributed in society. And when these particular resources are distributed, they lead to social class, which I'm sure you've heard of, or another word for it is socioeconomic position. So then people's socioeconomic position in society is usually determined by things like their level of education, how much income they have, what type of jobs they do, how prestigious their job is, for example. And this then shapes their access to what are called the social determinants of health, which you can see over here are things like your living conditions. So do you have good housing? Do you have childcare? What were your circumstances growing up as a child? They also influence your behaviors and your biological factors like nutrition. What are your dietary patterns? And they also influence psychosocial factors, so things like your level of stress. And in particular, one thing that people often don't realize is that in society, when we have people with different positions, different social classes, or different socioeconomic positions, we tend to compare ourselves to others. And those comparisons can actually be very stressful. So if you're constantly comparing yourself to somebody who has more, that generates stress. And so that is also part of how our social class and society influences our health. So as you can see, through these pathways, at the very end, we have impact on health. So this is how we come to see that there's what we call health inequities. So the unfair distribution of health. It shouldn't be that how much money you have influences your health, but that is currently how it is in our society. So first, I'm going to talk to you about trends in socioeconomic and ethnic inequities in diet quality using nationally representative data for Canada from 2004 to 2015. So these trends in inequities in diet quality have actually only been previously investigated in the US using nationally representative data, which is what the highest quality data. And so what these studies show is that these inequities are persisting. So they are not going away. And in some cases, they are widening. So we could look at these from various perspectives. We can look at differences between people with high and low income, high and low education, people who have food or are food insecure. And also the US studies have looked at differences between Black and white adults. But the limitation is we really only have these data for the US. They've only looked at absolute dietary gaps, which I'm going to explain in a bit. And I used the term socioeconomic position before, which is social class, and they've only looked at a few indicators of this. So like I mentioned here, they've looked at income, education, for example. Those are all indicators of your socioeconomic position. And they've only looked at these gaps for a few ethnic minority groups. So they're really missing a lot of groups. So when we're trying to quantify trends in inequities, we need to keep in mind that our findings can differ quite a bit depending on which indicators of socioeconomic position we're using, which ethnic groups we're examining, whether we're looking at absolute differences between groups or relative differences, or whether we're looking at gaps or gradients. So if we look at all of these, then we can have a more comprehensive perspective of inequities. So here are some examples of indicators of socioeconomic position. So it could be your income, your education, your occupation. Those are the three we typically use. But it also could be the amount of disadvantage in the area where you live. It could be how much wealth you have, which is more like, do you own a house? Do you own a car? And home ownership is another indicator, whether you actually own your home versus renting it, or your subjective social status is another. So there's quite a few indicators we could use. Now, in terms of ethnicity in the US, they really have only looked at a few ethnic groups. And so they looked at white people, Black people, Hispanic, and non-Hispanic Asian, only in a few studies. Usually they don't look at this often. And then everybody else is just put into a big group called other, which really conceals a lot of heterogeneity. So in Canada, we actually use quite a few more classifications, and you can see them listed on the slide. So we do have better data for ethnic groups. Now I mentioned you could look at absolute or relative differences. So absolute differences between groups are simply where you subtract the diet quality of the low socioeconomic position group from the high, or you could subtract, you could do differences between ethnic groups. Now it doesn't matter which you subtract from which, it just matters that you're clear which one you're doing so that people know how to interpret if it's a positive or negative number. In terms of relative inequities, this is where we're actually constructing a ratio. So we're showing whether the proportion, so as you can see here, if you're doing a ratio, you're going to end up, oh great, thank you. You're going to end up with a proportion of high to low SEP. Huh. Is it working? Oh, okay. Oh, there now, I can see it. Okay, great. So the other thing you can look at is gaps or gradients. So the gap is the simple difference between the lowest and the highest SEP group. So the lowest and the highest social class group, however you're measuring it, by income, by education, by occupation. But the gradient is actually taking account of the slope of the entire distribution, and it's also accounting for the size of those groups. So this, just by mentioning how you calculate it, I think you can see that the gradient is probably giving you more information about what is going on in the population. So it's a very useful measure, but it's very rarely used. Most studies just quantify the simple difference between the lowest and the highest SEP group. So what we wanted to do is to quantify the trends in absolute and relative gaps and gradients in diet quality using 3 indicators of socioeconomic position. And then we also wanted to look at gaps and gradients for according to Indigenous status and ethnicity in a nationally representative sample of adults in Canada. So we used data from a nationally representative survey from 2004 and 2015, and both surveys were designed to be comparable to enable us to do these types of analyses. And participants were adults and not pregnant or breastfeeding, and we removed people who reported no energy intake. So we used 3 indicators of SEP. So we used annual gross household income, educational attainment, and neighborhood deprivation. Then we also looked at Indigenous status and ethnicity. So in Canada, the way that this is asked is people are first asked if they are an Aboriginal person. And if they say no, then they're asked about their ethnicity. So they can't be say they're both Indigenous and Black, for example. They can only, if they're Indigenous, even partially Indigenous, they're counted as Indigenous in Canada. And then we have all these other groups, but we did condense them. Then we measured diet quality using an in-person 24-hour dietary recall. And so this used the automated multiple pass method, which you may have seen, which helps to minimize misreporting. And then we used the Healthy Eating Index 2015, which is a US index of all of components of the diet. So it's an index of the full quality of the diet. Then we looked at absolute gaps, as I mentioned earlier, which is just the difference in absolute diet quality between the highest and lowest SEP, and then relative gaps, which is the ratios. And then we looked at the gradients as well on an absolute and relative basis. And we use linear regression. So here you can see our participant characteristics, and these are weighted. So the HEI 2015, this is the diet quality score. It gives a total of up to 100 points. So you can see that people's diet quality is not great. It's only 55 in 2004, and it improves a little bit to 59 in 2015. And you can also see that the population is becoming less white over time. So this is principally due to immigration in Canada because we have very high levels of immigration. And you can see that people are actually becoming more educated because fewer people have less than a high school level of education over time. So here we see mean diet quality by SEP. So what I want to emphasize here is that you can see that when you're looking at the gaps between, according to income, here we go, and neighborhood deprivation, the gaps between the lowest and the highest groups are not very large. They're only about 3 points. But now look at education. We have almost a 10-point difference between the lowest and the highest education groups. So this is showing us that education is really an important determinant of diet quality in Canada, more so than income, which seems quite surprising. Now we're looking at the values for the actual gaps and gradients. So this is the gap. So there's a single value in each year because this is the actual gap. So if you subtract the highest from the lowest, this is the value that you're getting. And so the gap here is, oh sorry, you're doing it the other way around. It's the highest minus the lowest. So that the gap is 6 points, meaning that the highest SEP group has about 6 points higher diet quality in 2004 and about 9 points higher diet quality in 2015. So you can see that these gaps for education are quite large. And then we can look at the gradients as well, and you can see they're fairly similar. They're not a lot different than the actual gaps. But also note the p-values here, so you can see they're not significantly different. So they're not widening over time, they're staying stable. Now, when we look at the relative gaps and gradients, we see they're very small. There's not much happening here. If the ratio is close to 1, there isn't really much of a relative gap or gradient. Now here are some trends in diet quality by SEP and by sex. So just to orient you to this slide, you can see that these dark values here are males. So if you look at males, here is one of the lines, and here is the other line. So you can see that here, this is just a simple gap in 2004 compared to 2015. And it looks like this gap is getting quite a bit larger by 2015. Now, we also, and so also it looks like this slope is becoming steeper. It's quite, it's not very steep here. So it looks like there's something happening with the gradient as well. In females, it's not very intuitive just to look at the graph. You can't necessarily tell, but there actually was nothing going on in females. And then in males, and so sorry, this first was according to income. And then if we look at education, we can see that in males, the gaps seem to be getting slightly, maybe slightly larger, and the slope does seem to be quite a bit steeper here in 2015. So just to summarize what we saw in those graphs, the values that were actually statistically significant showed that the absolute gaps for males according to income and the absolute gradients for males according to income widened over time. And for education, the gradient widened over time as well in males. But in the total population, there was no change in inequities, and same in females. So what we see particularly here is that there's something going on with males, that the gaps in diet quality are widening over time. Now here is ethnicity. So what is really interesting to point out here, so this is 2000, you can see 2004 is in the blue and 2015 is in the gray. And what you see here, and this is just their absolute value. So 51.9 points out of 100 here for Indigenous people. Whites have slightly higher at 56, but then all the ethnic minority groups have better diet quality than Indigenous people and than white adults. And so what we see over time is that diet quality did improve in all groups. And what is also very interesting to note is that the diet quality of South Asian people was about 61.9 on a 100-point scale, which is similar to people with the highest income and with a bachelor's degree, so the highest education in Canada. So people who are ethnic minority groups are really doing probably among the best job of maintaining a good diet quality in Canada. Now these are just plotting the gaps in diet quality. So the gap compared to white people, which is why whites are not on the slide, because whites are the line of 0, basically. So this is just showing the same thing in a different way. Indigenous have poorer diet quality than whites, and all the other ethnic minority groups have better diet quality than whites. And we saw that the gaps were stable. Now, I just wanted to show this one slide. So UPF is ultra-processed food intake, which you've probably heard of, is by Carlos Monteiro in Brazil, who has devised the system of looking at ultra-processed food using the NOVA index. And what this is showing is the proportion of energy consumed from ultra-processed foods. So it can be thought of as another indicator of the quality of the diet. And you can see here that Indigenous people are consuming a lot of calories, over half of their calories from ultra-processed foods. Whites are getting close to 50%, but then all the other ethnic minority groups are consuming fewer ultra-processed foods. So for South Asians, for example, they're down at 31% of their energy from ultra-processed foods. So this suggests that might account for some of the things we're seeing in diet quality. So because, I should be more specific, because maybe the ethnic minority groups are maintaining some of their traditional cultural food practices. So they are cooking with whole foods. They're not eating as many packaged ultra-processed foods, and that's why they have higher diet quality than white people and Indigenous people. So we see overall that in Canada, diet quality is poor regardless of your social class or your ethnicity, and it did improve a bit over time. And we see that there are inequities for all three of the indicators that we examined, but they're the largest for education, and they're more than 5 points, which is what we consider to be a statistically meaningful, a clinically meaningful finding that could influence your health. We saw that in females and the overall population, trends were stable over time, and that in males, some of the gaps and gradients widened. But they widened by a small amount, just by 2.5 points, so this may not be meaningful. And then we also saw that Indigenous status and ethnicity actually matter for your diet quality, but maybe in different ways. It seems that ethnic minority groups have higher diet quality than whites, Indigenous have poorer diet quality, and that the size of these gaps is actually meaningful. So it could be about 5 points poorer than whites, or even 6.4 points better than whites. But these gaps were stable over time. So a few takeaways are that measurement matters. If we only looked at one indicator of SEP, we would have missed a lot that was going on in the population. If we didn't stratify the findings by sex, if we didn't look at gaps and gradients, relative and absolute differences, we would have missed a lot that was going on. Or if we lumped all the ethnic groups into an other group, we would have missed a lot of things going on. So inequities seem to be largest for education in Canada. So that tells us it's not simply about the cost of healthy food. There's something else going on that is influencing people's ability to have a good diet quality. And maybe it's things about differentials in knowledge, your status and influence that comes with education that influences your diet quality. So this could be because in Canada, it's very rare now not to have a high school education. So it could be that people who don't have a high school education are just a very severely disadvantaged group that cannot work, for example, and that just have very poor status in society now because everybody else has a high school education and often a university education. We do see that people with a higher SEP have better diet quality, but it's actually still poor. It's still a failing grade. If you think of 60%, right, it's like about 60 points on 100 points. That's not really something to be super proud of in terms of diet quality. So we would want to see people closer to values of 80. And so what we think is that there must be some sort of broader structural factors that are helping ethnic minorities to have a high diet quality. So things that are helping them to maintain their traditional cultural food practices. So this could be Canada's official policy of multiculturalism, which helps people to maintain their original cultural traditions. But somehow these same factors don't seem to be helping Indigenous adults. So we need to do more to improve diet quality among Indigenous adults. And it's also important to recognize that white adults still experience disadvantages. So we do see this phenomenon called deaths of despair, where in the US and Canada, males with less than a high school education or with a high school education tend to be dying from alcohol and drugs and suicide. And so it's not fair to say that white adults don't also experience disadvantages. But we did see in general that our general conclusion is that dietary inequities in Canada primarily relate to education and Indigenous status.
Bueno, aló. Sí, bueno, es para el Facebook igual. Entonces, un pequeño recap de lo que nos ha presentado por el momento la profesora. Básicamente que la literatura evidencia diferencias en calidad de la dieta según ingreso, nivel educativo, etnia y seguridad alimentaria, ¿verdad? En diferentes países. Sin embargo, ella nos comenta que las principales limitaciones es que muchos de los estudios se han hecho en Estados Unidos, que solo cuantifican una diferencia absoluta y no una diferencia relativa, y explicó ahí un poco la diferencia entre esos dos términos, y que utilizan pocas categorías para el nivel socioeconómico. Entonces, el objetivo que ella tuvo en esta serie de estudios fue cuantificar las tendencias en las brechas absolutas y relativas de la calidad de la dieta entre 2 años, 2004 y 2015, y utilizó 3 indicadores de nivel socioeconómico, estatus indígena y etnicidad en una muestra nacionalmente representativa de adultos. Ella utilizó datos de la encuesta comunitaria de Canadá, Nutrición, ¿verdad? En el 2004 con más o menos 20,000 participantes, 2015 13,000 participantes, entonces una muestra bastante grande. Y bueno, lo que encontró principalmente fue que la calidad de la dieta es pobre en todos los niveles socioeconómicos y en todos los grupos étnicos. Sin embargo, sí detectó que mejoraron con el tiempo, ¿verdad? Entonces, eso es importante. Detectó diferencias en cuanto al estado indígena y etnicidad, entonces todos los grupos étnicos minoritarios tuvieron una mayor calidad de la dieta que los adultos blancos, y los adultos de descendencia indígena tuvieron menor calidad dietética que adultos de etnia blanca, si comprendí bien. Entonces la conclusión fue, bueno, o como un mensaje, ¿verdad?, de toda esta parte, es que las inequidades dietéticas en Canadá se relacionan principalmente con educación y también con estado indígena. Si les parece, podemos dejar los últimos 15 minutos para preguntas, para que ella siga con la siguiente parte, pero muy interesante esta primera sección, entonces...
Great, thanks so much. Okay, so now we'll go on to the second topic. It's much shorter, and we're just going to talk about some mechanisms. So how does your socioeconomic position actually influence your health? Because somehow it actually has to interact with your biology if it's going to shape your health. And so we have done some investigations to look at this question. So what we've used is a procedure called structural equation modeling. And basically what it is doing, it's called a mediation analysis. So we have low SEP groups here, and then we have a health outcome here, which in this case is morbidity and mortality from cancer. So getting sick from cancer and dying from cancer. And then we have factors that can act as mediators. So what we're saying here is your SEP shapes your, whether you smoke, whether you're physically active, your body weight, whether you eat fruit and vegetables, and how much alcohol you drink. And that these factors are the way that your SEP influences your biology, because we know, for example, if you eat fruit and vegetables, that's beneficial for your health. And that could then go on and influence your risk of cancer. So when we did this study, what we found is that all of these mediators collectively explained almost half of the associations between your socioeconomic position and whether you got cancer or died from cancer. So that's a lot of explanatory power, showing that these factors are very important. And in particular, smoking explains 16% of these associations. So we see how important it is for shaping how SEP gets under the skin. And obesity was also a mediator in females. Then we also looked at mechanisms through which SEP shapes risk of CVD, which is cardiovascular disease. So whether you contracted cardiovascular disease or died from it. Now you can see this is a very complex mediation model because we are looking not just at things like physical inactivity, but also whether you had high blood pressure, for example, or whether you had diabetes. And what we saw in this model is that all of these factors explained a lot more, up to almost 3/4 of the associations between SEP and cardiovascular disease. And again, smoking was the most important mediator. And what I mean by independent is that the pathway from this pathway was significant through smoking alone, but it also, smoking acted through other mediators. So it influenced, up here, the one that's covered up is obesity. So smoking influenced your risk of obesity, which then went on to shape your risk of cardiovascular disease as well. And we also saw PA means physical activity. That was actually also an important mediator. And the last one we did was that we looked at mechanisms through which SEP shapes risk of all-cause mortality. So again, here we're looking at more of the smoking, physical activity, those factors again. And what we saw here was quite different. So we saw that altogether, they did not mediate these associations. And that was actually because they were offsetting positive and negative impacts of some of these. And so overall, they did not together explain the associations, but some of the mediators were still individually meaningful. Again, we saw smoking is an important mediator of the associations, and physical activity was an important mediator in females. So this really showed us that smoking is a really key mechanism through which socioeconomic inequities in health and mortality come to be. And obesity and physical activity also mediated some of these inequities. But interestingly, fruit and vegetable intake and alcohol intake did not mediate inequities.
Entonces, bueno, de acuerdo con los modelos que ella utilizó en este otro estudio, se detectó que el fumado es un mecanismo clave a través del cual surgen inequidades socioeconómicas en salud y mortalidad, que la obesidad y la inactividad física median esas inequidades en salud y mortalidad, entonces juegan un rol importante. Y algo interesante que observó fue que el consumo de frutas, vegetales y alcohol no influyó en esas inequidades. Entonces, cuando se analizan como de forma separada, esos comportamientos no fueron tan relevantes estadísticamente.
All right, so now that we know that there are inequities, how they come to be, how can we actually address them and reduce them? So this is a randomized controlled trial that we did of the impact of a healthy food subsidy in farmers markets on people's diet quality. So this study was really about reducing food insecurity. So what is food insecurity? Well, in Canada, we define it as having inadequate or insecure access to food due to finances. So it's always about not being able to afford enough healthy food, the way that we measure it in Canada. So it can range in severity from marginal, which is where you're just worrying about running out of food or limiting the variety of food you're eating. Then it could be moderate, where you're actually compromising the quality or quantity of food you eat. And in severe cases, you might be skipping meals or not eating for an entire day. And we think that healthy food subsidies in farmers markets may help to address this issue. So we think they are giving people subsidies is really a more dignified approach to accessing food. In Canada, we tend to send people to food banks, which are sites where they can receive food, but they can only receive a limited amount of food, and it's not very typically a very good quality food, and they also have to prove that they are poor enough to need the food. So it's not a great experience for people. So instead, why don't we give people money where they can go to the grocery store like everybody else and buy healthy foods that they actually enjoy eating? So that's the premise behind the farmers market subsidy. Now, farmers markets can actually have a lot more benefits than simply shopping in a grocery store. So people are out interacting with community members, so that could improve their social connections, improve their mental well-being, and it also supports local food systems and economies. So they might be a win-win in terms of improving people's physical, social, mental health, and also the health of the planet. So we know from evidence to date that it does seem like healthy food subsidies in farmers markets can lead to increased fruit and vegetable intake and reduce food insecurity. But all the studies to date have had major limitations. So they've been very small, had high attrition. They haven't measured these values very comprehensively, and they have not had control groups, which is a very key limitation. So we specifically studied the BC Farmers Market Nutrition Coupon Program. So this is an existing government program in the province of British Columbia in Canada. This is the province where Vancouver is located. You may have heard of Vancouver. And it serves about 18,000 families at present. It's funded by the government, by the BC Ministry of Health. And at the time of the study in 2019, they were giving a subsidy of $21 per week per household for 16 weeks during the summer. So keep in mind, this study was conducted in Canada. The farmers market period is limited. It's very short because the snow is coming. Usually farmers markets, they can often be outside. And as soon as the snow comes, we can't grow very much unless it's grown inside a greenhouse. So that's why our study had to be time limited. It had to be short to meet the season. And the subsidies can be used to buy fruit and vegetables and dairy meat and other healthy foods. They can only be used for healthy foods. And people can participate in skill building activities if they would like to, but they are not required to. So this could be like cooking or gardening classes. So we wanted to examine the impact of the BC Farmers Market Nutrition Coupon Program. That's what the abbreviation stands for. Immediately post-intervention, and then we wanted to look at what happened 16 weeks after the intervention ended. So our primary outcome was diet quality, and we also looked at household food insecurity, mental well-being, and sense of community. So participants had to be 18 years of age, and they had to meet the existing criteria to be in the BC Farmers Market Nutrition Coupon Program. So they had to be low income. We wanted to have the primary food shoppers for the household because only they would know what the coupons were spent on. They had to have less than 8 people in the home because it's only a subsidy based on a household. So every household, regardless of how large it was, got the same subsidy amount. So we didn't want to dilute that subsidy amount too much by having, say, 10 people in the home. And they couldn't have been in the program before. So as I mentioned, we did a randomized controlled trial in 2019. People were randomized to be in the intervention group, which is the first one listed on the slide. And they got 16 weeks of coupons valued at $21 a week. And they got them over a bit shorter period, not the full 16 weeks. And that's because it took us some time to actually recruit everybody into the study. So we had to shorten the intervention a bit because, as I mentioned, winter is coming when the program does not operate anymore. They could use the subsidy on healthy foods and have be in skill building activities if they wanted, and the control group did not get any intervention. So we collected data at baseline, then they had the intervention, and then post-intervention and 16 weeks post-intervention. So our primary outcome was the same as I mentioned before. It was the Healthy Eating Index 2015 score, which is a measure of diet quality from 0 to 100. And then the secondary outcomes were household food insecurity in the past 30 days using a validated 18-item questionnaire, and then mental well-being and sense of community. And we used mixed effects linear regression adjusted for these variables on the slide, and intention to treat analysis. So here you can see we actually had very little dropout. Overall, the dropout was 15% over the course of the study, which is quite low. And in terms of our results, most of the people were female in the study, and that's because they tend to be primary food shoppers. Most were food insecure, had low incomes, had a diet quality score of about 60, which is higher than we actually had expected, and most had a low education. We saw that almost all of the coupons were distributed, and of those, nearly every single one was redeemed. And people mostly use the coupons to buy fruits and vegetables. Now, we also did a qualitative study where we got people to tell us about their experiences in the program. So I've included some of those quotes here so that you can see what people said about the program. So they really enjoyed the program and said, you know, I have more food in my fridge. My fridge is actually full. And some people use the extra money to put their kids in swimming lessons, for example. We can also see that people really love that they could eat better foods and that they could eat higher quality foods, that the food in their fridge didn't go bad quickly because it was fresher from the farmers markets. And they also really felt proud that they could go to the grocery store on their own and buy the foods that they wanted, and it made them feel proud. So this slide shows the differences in diet quality between the intervention and control groups, and you can see that the p-value is not significant. So there was no difference in diet quality between the two groups. So it was basically 0 at post-intervention, and 4 months later, 16 weeks, the difference was like 1 point, which is not meaningful. But you can see that household food insecurity declined significantly. It declined by 79% at post-intervention, which is the first line here. And then you can see that this decline, 4 months later, even with no intervention, it was maintained. And these values are significant. And you can see that what the program was actually doing was reducing severe food insecurity. That's where the majority of the reductions were seen. So now moving on to more of the mental well-being benefits, you can see that people who were low income said they felt like scum sometimes, and that having the coupons made them feel like part of the community. It also helped them to build social connections. So they talked about how people at the farmers market were very energetic. They were not grumpy, whereas at the grocery store they were grumpy. And they felt like they just had fun connecting with other people on a Saturday. Now, we can see here in terms of the quantitative results, we did see this partially reflected in the quantitative results. So a p-value less than 0.1 is indicative of a trend. So you can see here that it looks like there are some differences that did not reach statistical significance in mental well-being and in sense of community immediately after the intervention ended, and that some of these differences in mental well-being may have been maintained, but I caution, of course, these are not statistically significant. These were secondary outcomes, so we were not powered for these analyses, so hopefully, probably, if we had a larger sample size, we may have seen these reach statistical significance. Now, we did have some contamination. So people in the intervention group, 4 of them said they did not receive coupons, and 26 people in the control group said they received coupons, but it's not clear how many they received. So what we did is a per protocol and an as treated analysis, which is when you so in the per protocol analysis, you only include those who received the correct intervention. So that means our sample size declined by 30 people. We dropped these people from the analysis and checked if that made a difference to our findings, and it did not. And then we did an as-treated analysis, which is where we switched people into the group to reflect that they what they received. So these 4 people who said they got no coupons were analyzed as part of the coupon group, and the 26 control who said they got the coupons were analyzed as part of the intervention group. And that also made no difference to our findings. So that does not account for the lack of impact of the program. So in summary, we saw no significant impact on diet quality, but we did see that household food insecurity declined by 79% post-intervention, and this was sustained. Now, why would these reductions be sustained? Well, what we think happened is that because the coupons were distributed by community organizations, that they helped to connect people to other sources of financial and material support that they then accessed after the program ended. So, for example, some of the coupons were given out by social housing providers. So maybe they help people to find cheaper sources of housing, and that then after the program ended, they kept accessing these social housing supports. So they then still had more money to buy food. And we saw trends for improved mental well-being and sense of community, and the one trend for mental well-being was sustained. So why do we think food insecurity declined but diet quality did not improve? Well, a lot of people in the study were parents. And what we think happened is that parents were using the subsidies to feed their children. So the benefits were seen at a household level. So household food insecurity declined, but the diet quality of adults, and those are the only people we measured, we did not measure the diet quality of children. So there wasn't enough money to improve the diet quality of the adults and the children. So the adults were obviously using the money to feed their children, we think, and that maybe the diet quality of children improved, but we didn't see this because we didn't not measure it. And when we look at the size of the subsidy, the households on average had 3 people, and this is actually only $1 a person per day, which in Canada does not go very far. So in our next steps, we actually want to do another RCT, and we're going to include children this time, and we're going to do a dose response study. So we want to know what amount of subsidy is needed to improve the diet quality of children and adults in these households. So we're going to have 4 groups. So we'll have a usual subsidy, and it'll be slightly higher because the study will be in 2015, and of course there's been a lot of inflation since then. And then we'll have a subsidy group that gets 1.5 times more money, a group that gets double the money, and one that gets 2.5 times more money. And what we think is going to happen is that probably at the lower subsidy levels, these 2 here, only children's diet quality will improve. But maybe at the top 2 doses, we'll see that both adult and children's diet quality will improve. And the last one I wanted to mention is we are doing a randomized controlled trial of a healthy food prescription incentive program for adults who have diabetes and food insecurity. So I'm just going to briefly tell you about the study design. So this study is looking at whether a healthy food prescription incentive program can improve blood glucose levels in adults with food insecurity and diabetes. And what this type of program is it's called a social prescribing intervention, where you actually identify people in the hospital, in a primary care setting. So in some sort of medical setting, you're identifying them as food insecure and having diabetes. And then you intervene with them and give them a healthy food subsidy that they can use in grocery stores. So that is another study that is ongoing right now that we're doing. So this study will have 594 adults with food insecurity and diabetes, and they'll be randomized to get the healthy food prescription incentive, meaning they will get a prescription that says please eat these healthy foods, and we're going to give you $1.50 per day per household member for 12 months to help you to actually buy the healthy foods. And then the comparison or the control group will just get the healthy food prescription, but they will not get a financial subsidy. And this just kind of shows how we think the program will work. So the incentive program will reduce food insecurity, which will then improve their diet quality and help them to manage their diabetes and have less diabetes complications.
Bueno, entonces en esta última parte lo que nos compartió la profesora fueron 2 estudios que ellos les llaman ensayos clínicos aleatorizados pragmáticos, que básicamente lo que hacen es que miden la efectividad de una intervención, ¿verdad? No la eficacia, entonces en un escenario real, ¿verdad? Y el primer estudio básicamente fue un subsidio que dieron a los participantes. Esto era en el marco de un programa, si no me equivoco, ya existente del gobierno canadiense, y estaban evaluándolo. Entonces se da un subsidio, quiere decir que les dan cuponcitos a las personas para que los puedan usar en la Feria del Agricultor. Participaron alrededor de 300 personas y de los principales resultados fue que no mejoró la calidad dietética, según cómo lo midieron, ¿verdad? Pero sí mejoraron los niveles de inseguridad alimentaria. Entonces ella hizo un análisis ahí de por qué creen que se dio eso. Básicamente se pensó que fue porque se mejoró la situación del hogar, entonces eso se refleja en una mejora en la inseguridad alimentaria. Sin embargo, creen que la calidad dietética tal vez mejoró en los niños y no necesariamente en los adultos. Esa fue como la hipótesis de ese resultado que obtuvieron. Y sí se mostró una tendencia hacia mejorar la salud mental y un sentimiento de pertenencia a la comunidad al poder, ¿verdad?, estas personas acceder entonces a la Feria del Agricultor. Sin embargo, esos resultados no fueron estadísticamente significativos. Ahora, el segundo estudio que nos presentó es uno que ahorita está en proceso, entonces no presentó resultados, pero básicamente es de prescripción de alimentos saludables, y esta es una tendencia nueva que hay ahora le llaman a veces food as medicine, alimentos como medicina. Entonces se están haciendo ahora estudios en diferentes lugares que lo que hacen es que a los pacientes en el hospital se les dice, bueno, consuman esta cantidad y se les da como un incentivo económico. Y este estudio es en adultos con diabetes e inseguridad alimentaria, y planean incluir alrededor de 600 adultos con inseguridad alimentaria y diabetes.
Okay, and just to conclude, this is what I'm missing back home. So this is why it's great to be in Costa Rica. Thanks, everybody. And I'm happy to take any questions.
Bueno, le damos un aplauso a la profesora. Y bueno, si alguien tiene alguna pregunta, la pueden realizar, si quieren hacerla en inglés o si quieren hacerla en español y yo le traduzco con mucho gusto. Uh-huh. Puntos extra. Sí, es que es más para el Facebook, yo creo, profe.
Ahora sí, en primer lugar.
Espere. Sí se escucha aquí, yo no sé si en línea.
Bueno, voy a repetir. Okay. En primer lugar, agradecerle a la doctora y a la Escuela de Nutrición, ¿verdad? Pues la invitación de hacernos partícipes en esta tarde de esta actividad, y siendo un tema que tiene que ver con las desigualdades y las inequidades en salud, ¿verdad? Como es en el ámbito de la nutrición, pues no es ajeno a lo que nosotros trabajamos aquí en la Escuela de Salud Pública. Y sobre todo los chicos que tenemos en este momento en el proyecto formativo de investigación en promoción de la salud. Hay una pregunta, digamos, no sé si tal vez no tomé bien la idea, Me llama la atención esa asociación encontrada entre el fumado y las inequidades. Si ella podría explicarnos un poco mejor cuál es, o sea, hay una asociación, pero el mecanismo por el cual se encuentra, digamos, que hay inequidad específicamente con la gente que fuma. Gracias.
Gracias, profe. Yes. So she is wondering about the association that you found between smoking and the health outcomes. If you could expand a little bit more the inequity that you found in that sense, or yeah, how do you explain like that association?
Sure. So I'm not sure how it is in Costa Rica, but in Canada and the US, people with lower incomes, lower levels of education, less poor quality jobs tend to smoke more. So higher income people in Canada and the US really don't smoke very much at all. The rates are much lower. So that is what we think is explaining why smoking is such an important mechanism. Yeah.
Que en Canadá el fumado es mucho más prevalente en poblaciones de niveles socioeconómicos más bajos y niveles educativos más bajos, entonces que por ahí probablemente sea que va la explicación de eso. Ajá. Sí.
I want to thank you very much for your presentation and your very interesting work. I just have a question. When you analyzed the mediation, you did that mediation analysis, you only put one food group, the fruit and vegetables. What happened if we look at some other groups like sugar sweetened beverage or red meat, processed meat?
Yeah, that is a fantastic question, and it's because of that the survey data that we used. So we didn't, it's a different survey than I presented for the trends, all those data. And this data is, this survey is not a nutrition specific survey, so they only ask, I think, 2 questions about nutrition, and one is fruit and veg intake, and the other one I think is sugar sweetened beverage intake. So we really, that was kind of their only choices. Yeah.
Bueno, yo tengo una preguntita. I have one or a couple questions. Just to make sure I understood correctly, the farmers market coupon program, it's a government program. It's in place. Okay,
Yes,
entonces
exactly.
sí, el
Runs
programa
every
de
year.
cupón. Okay. And what were the policy implications of your findings? ¿Cuáles fueron como las implicaciones políticas de los resultados que obtuvo? Si a raíz del estudio se decidió continuar con el programa, si el programa continúa implementándose o si más bien fue como un desmotivante ver que no se estaba afectando la calidad nutricional. Basically, like, were they happy to see those results and they said, okay, this is reason to continue the program, or did it have the opposite effect where they, I don't know, decided to cut funding on it? Yeah, I'm curious.
Yeah, so our findings were actually just published last year, so they haven't had any impact to date. There are no plans, though, to discontinue the program. I do know that. So whether they'll think about increasing the subsidy, I mean, that's what we are hoping, and that's what we recommend is, can we increase the subsidy and maybe provide it on a per person basis so that larger households get more money? But of course, that's out of our hands, so we don't know if the government will make any changes.
Sí, entonces ella comenta que el estudio, los resultados se publicaron hasta el año pasado, entonces que todavía no se sabe a ciencia cierta, pero no hay planes de recortarlo. Lo que ellos recomendaron fue mantener el subsidio o incluso aumentarlo para que sea un valor monetario por persona en el hogar. Okay, and then the other question I had was related, you presented data from 2004 and 2015, that was the trend. How often is dietary data collected in Canada? I'm curious.
Yeah, and it's not great. We don't do it often. So in the US, do it often. So in the US, they do it every year. And in Canada, that is the most recent data. So 2015 was the last time that they did an actual full nutrition survey. And as I mentioned a few questions ago, they do collect some very limited information every year, but like I said, it's just fruit and veg and a few others. So we don't know much about nutrition in Canada using nationally representative data. So we're hoping there's going to be another survey soon.
Sí, gracias. Lo que le preguntaba era con qué frecuencia recopilan datos dietéticos o encuesta nacional de nutrición. Entonces lo que nos comenta es que, por ejemplo, en Estados Unidos hay una encuesta de nutrición que se hace todos los años, pero en Canadá no es tan frecuente y que los datos más recientes que tienen de consumo de alimentos son los del 2015. Entonces es una limitación, ¿verdad?, en ese sentido. ¿Hay alguna pregunta? Sí.
Well, thank you so much. I have more of a comment, maybe. Well, we do not study only like nutrition. We're here when we study health promotion, and like connecting all of like both of these studies with what we learn every day in school, and like through also the investigations that we're working on right now. I feel like like a way to empower more these studies are also like working with not only the coupons or the prescriptions, but the educational part to help like the community in Canada to learn how to distribute this food and how to create healthier and more nutritious, more like meals, not only giving them the subsidies, because maybe for some people it's not that easy to figure out what to eat. And we also saw like the educational like comparison we made, well, you made is well, very different for every ethnicity, or so probably to involve the educational part a little bit more. Hopefully if they like continue with the program and find better ways of working with it, but also working in that part could be very like good for the community, like in Canada, to make the program stronger.
Yeah, thanks. Those are great comments. So as part of the program, like I mentioned, they do have the option of being in nutrition skill building, things like cooking classes and gardening. But one important point to keep in mind is that we know that actually people who are food insecure don't have poorer cooking skills than people who are food secure. And this has actually been studied in Canada, and they've shown that it's actually virtually identical. They have the same cooking skills as people with who are food secure. So food insecurity is always a problem of inadequate income. It's not a problem of skills. But at the same time, your point is also excellent, because in general, we see in society that people don't cook as much, right? They tend to eat out, especially with Uber Eats and how easy it is to get food delivered to your home. So we don't want to single out food insecure people and say, well, the problem is because you're not cooking at home and everybody else is. That isn't the case. But the problem is potentially that everybody is not cooking at home. So definitely, yes, there is a role for teaching people those important food skills.
Thank you. I'm not going to translate all that because it was a lot. Thank you. ¿Alguna otra pregunta? Sí.
Okay, thank you. And this was an investigation from the university, right? 100%? 100%? This was.
Oh, yes.
Yes. Okay. And how is the role of the Canada government in this kind of topics? I mean, does they create this kind of programs sometimes for the people of low resources, or is something that they mostly don't do?
Yeah, so that's a fantastic question as well. So in Canada right now, we actually don't, this program that we studied is the largest and basically kind of the only government approach to address food insecurity. So mostly what we do is we tell people to go to food banks, and that's also one of the primary responses in the US, but the US actually does a better job of addressing food insecurity because they do have a government program that provides people with money to buy healthy foods in grocery stores, which we do not have in Canada. So in Canada, when people are food insecure, we say go to a food bank, which, as I kind of described, is a place where actually just normal people like me will donate food. We donate our leftover food, what we don't want to eat. And so usually it's all canned in boxes, and they will provide a bit of fresh food, like they will get a little bit of fresh meat, a little bit of fresh fruit and vegetables, but mostly everything is canned and in boxes and not very healthy. So this program that we studied is very innovative in Canada, and we really, like I said, it's the largest, and we don't have really other government funded programs.
Thank you. Gracias. Y la pregunta, ¿cuál es tu nombre? Gerald, les preguntaba que cuál era el rol como del gobierno canadiense hacia soluciones para la inseguridad alimentaria. Entonces la profesora nos comentó un poco que se dan mucho los bancos de alimentos en Canadá también, que es curioso porque aquí en el país tenemos un banco, ¿verdad?, de alimentos, pero en Canadá sí es como una iniciativa, ¿verdad?, es como lo más común, lo más tradicional. Entonces esta iniciativa de los intervenir a través de las ferias del agricultor es como una intervención un poco más novedosa que lo tradicional, ¿verdad? Yo tenía one more question. Bueno, adelante.
Hi. I don't want to ask a question, but I speak for my colleagues. Thank you very much for this presentation and excellent work. And thank you for, what do you say, compartir?
Sharing.
Basically, this.
Okay.
Thank you.
Gracias. Yes. Muchas gracias.
Thank you for coming and for your interest.
Okay. Bueno, podemos dar por concluida entonces la sesión. Muchas gracias a ustedes por participar y por hacer preguntas también. Y le agradecemos a la Escuela de Salud Pública por habernos prestado este espacio, porque en la escuela el auditorio estaba ocupado. Y sí, agradecerles. And thank you, Dr. Olstad, for your talk.
Thank you, everyone.
Gracias.